Case 3. A 32-year-old non-smoker is admitted with severe shortness of breath. Initial investigation: hemoglobin 14, WBC 15.4, predominant neutrophils, partial pressure of CO2 5.4, oxygen 8.4, peak expiratory flow rate 80 liters per second, flow volume loop A, mark expiratory flow limitation compatible with severe obstructive airway disease. Despite treatment, his condition deteriorated over 12 hours and he is electively ventilated via a cuffed endotracheal tube. He remains ventilated for 4 weeks. 4 months after discharge, a repeat flow volume loop is obtained. This is A, this is B. What is the diagnosis would account for the first and second flow volume loop? First, flow volume loop, severe reversible obstructive airways disease, almost certainly an ineffective exacerbation of asthma. Obstructive pattern with reduced expiratory flow and compatible blood gases, type 1 respiratory failure with normal raised partial pressure of CO2. Second flow volume loop, variable extrathoracic tracheal obstruction, most likely post-intubation tracheal stenosis, following 4 weeks of endotracheal intubation. The expiratory limb is essentially normal, showing that lower airway obstruction has resolved. The inspiratory limb is flattened with reduced MIF 50, inspiratory flow at 50% of vital capacity to about half normal. Typical of variable extrathoracic obstruction. Discussion. In variable extrathoracic obstruction, example subglottic tracheal stenosis above the thoracic inlet, focal cord dysfunction, inspiratory limb is flattened, inspiratory narrowing, the extrathoracic airway, expiratory limb is relatively preserved. In fixed large airway obstruction, fixed tracheal stenosis, intrathoracic tumor compressing the trachea, both inspiratory and expiratory limbs are flattened, giving a box-shaped loop. Likely cause here is long-standing or long-term endotracheal intubation leading to tracheal mucosal injury, scarring, and stenosis at the cuff site. The patient ideally should have been managed earlier with tracheostomy once prolonged ventilation was anticipated. Other causes of variable extrathoracic obstruction to remember: bilateral focal cord palsy, laryngeal or upper tracheal malignancy, infective or inflammatory lesions, granulomatous with polyangiitis, syphilitic or TB, laryngotracheal disease. Further evaluation in this patient would include CT, neck, chest, and bronchoscopy to define the stenosis and plain intervention, endoscopic dilation, stent, or surgical resection with reconstruction.